Douglas Koch, came from Texas, a long flight. And I thank you because you are going to talk about one of the most controversial issues, which is to perform refractive exchange for presbyopic indication. Thank you, Douglas.
Thank you very much, Jorge. Yeah, I think you're going to hear a lot of what has been said in these last two excellent talks. But I'm really, Ron asked me to focus on presbyopes and what we should be doing with refractive lens exchange in presbyopes. I don't know how I get rid of that. Let's try again here. Don't know why that came up. All right. Got it. Okay. So I think really, when you think about refractive lens exchange in presbyopes, I like to group them into three categories: hyperopes, and you've heard this very well in the prior two talks, hyperopes, myopes, and emmetropes. Hyperopes really are the most ideal patients because they have poor vision at all distances, no risk, very low risk of retinal detachment, and they often have a crowded anterior segment that would benefit by removing the lens. When do you do it? Well, if they have poor uncorrected distance vision, they have clear visual needs or demands, they're contact lens intolerant or firmly reject this option. And you can do monovision, and I like monovision because these are young people. We don't know what their retina is going to look like in 30 or 40 years. And they may do better with a monofocal lens in monovision than they would with a diffractive lens implant. Trifocals are great. They're getting better, and the quality is getting better. But you have to really be careful. If they're real low hyperopes, say +0.5, they might be unhappy with the glare and the halo from that was different than what they experienced with their uncorrected vision, even if it was 20/25 or 20/30. And my favorite really is the light adjustable lens, because I can put that in and I can dial in what I want for the patient, and the patient can really tell me what to do post-operatively. The accuracy we found with the RX sight is over 90% with a half diopter of target, including post-LASIK eyes. You can dial in the magnitude of the near that they can need and that they tolerate. It has negative spherical aberration, which is a nice benefit in a post-myopic LASIK eye. With post-LASIK eyes, if you're thinking of presbyopes, the IOL calculation accuracy in post-LASIK eyes is only about 75% within a half diopter of target. And so with trifocal lenses, there's going to be concerns if you're going to put that in a post-LASIK eye that wants refractive lens exchange. And it's harder to do adjustment on the cornea in a post-LASIK eye if you miss your target. So these are our results, and I would just call your attention to this portion here. The percentage within a half diopter at Baylor, 96%, post-LASIK eyes, 93%, even RK eyes, 84%, which is far better than what we could have achieved with standard IOL calculations. You also have this interesting thing that when you treat the RX sight lens in a minus direction, going to targeting -5 to -2.5, you double the negative spherical aberration. And what you get from that, we use the VAO Optico to confirm that, is you get a 2.5 diopter range at the 20/30 level. So these patients get a big range of vision with good overlap, and it gets back to Dr. Kapoor's point, which is, you're not making them real minus, they're not making them -150, and yet you still have some good near. The RX sight LAL Plus is interesting because it has an EDOF characteristic, which is a central steepening that actually extends the near vision as well, and that's something we've had good luck using in these patients as well. Okay, so now we've talked about hyperopes. Let's turn to presbyopic emmetropes. Well, you have to be careful on these patients, to my view, because if you're going to operate on a presbyope who is emmetropic and you don't nail the distance vision, you've got a patient who's really unhappy. So I go very cautiously in these patients. And my thought is maybe just do one eye for near. Do a contact lens trial, and you can use a monofocal IOL, you can use the RX sight, And frankly, you could do a hyperopic LASIK on this patient, which would be just fine. You're not aiming for that much minus. You're not going to distort the cornea that much. But you have to weigh all the various options for these patients, I think, before you jump in and do refractive lens exchange. And sure, the lens may be dysfunctional at age 45 or 48, but if they're 20/20 uncorrected at distance, I'm a go slow approach with these. Now, finally, if we turn to myopes, and this has been addressed, the issues are several, of course. If it's a low myope, these patients have great uncorrected vision, and you have to, with both eyes, and they're used to having this fantastic reading vision, computer vision. Taking that away, you're not really maybe benefiting that patient, and of course, the risk of retinal detachment. And so I called on my good friend Oliver Findle in the MyoPred study. See, I'm one American who actually likes my European colleagues, unlike my president. So this study is really a fantastic study done by ESCRS. And it looks at the influence of posterior vitreous detachment on retinal detachment after lens surgery in myopic eyes. And these are 3-year results. And the inclusion criteria, 21 years or older, axial length of 25 or higher, no other comorbidities. Getting back again to Dr. Kapoor's point about if they have some other retinal pathology, you really want to be careful. So here's the baseline vitreous status. It's interesting that that they had a study group and they had a fellow eye group, that about half of the patients had a complete posterior vitreous detachment, 25% had incomplete, and 9% had no posterior vitreous detachment. 11% of them they really couldn't tell from the OCT readings. So the time to complete the posterior vitreous detachment, if they didn't have one at 12 months, 25% of the patients went on to have a posterior vitreous detachment following lens surgery. If they had an incomplete posterior vitreous detachment at 12 months, 43% of the patients had went on to get a complete posterior vitreous detachment. That tells you what you're doing to the vitreous if you're removing the lens. And look at the incidence of retinal detachment. If they started with a complete posterior vitreous detachment at 3 years, 0.4%. If they had no or an incomplete posterior vitreous detachment, there's a 3.4% incidence of retinal detachment. So that's 1 in 30 that are getting a retinal detachment. It's not a small number. So the conclusion from their study is that eyes with no or incomplete PVD before surgery had significantly higher RD risk than eyes with complete posterior vitreous detachment. Again, 3.4% versus 0.4%. So the preoperative status of the vitreous is a useful parameter for RD risk. And they also, I didn't have time to go through all this, but the high risk group are young males. We know that from all other kinds of studies. Men under age 50 or even under age 60 are at much greater risk than others. So they're going to be presenting the 5-year data, which I'm really looking forward to hearing at the ESCRS Congress in Copenhagen. So myopic presbyopes. So again, low myopia, do nothing to, do nothing to cause them to lose good near vision. So that I worded that incorrectly. And if they really do want some monovision, they have a clear lens, you want to avoid the surgery, LASIK's not a bad idea. You could do monovision with that. The other thing to think about is a myopic presbyope, maybe do a phakic IOL in these patients. Admittedly, the target audience for phakic IOLs is younger, but a phakic IOL can be a placeholder if there's enough space in the anterior segment and the risk of retinal detachment is less, and then we can let the vitreous cavity, the vitreous status evolve naturally rather than precipitating an acute posterior vitreous detachment. And we have new presbyopia correcting models, the STAR EVO. We have lenses that are available in Italy, the CARE Group IPCL, the Optec Artiplus, which is coming along. So, and there's really a low risk of cataract with a STAR EVO lens. And guess what? If a cataract occurs, you just do lens exchange, which you've been able at least to delay it. Now, if they have an early cataract, well then, sure, you could do refractive lens exchange. Again, especially if there's a PVD present and there's no retinal pathology. So, final thoughts. Cornea curvature changes with age. It goes to an against the rule shift to 3/8 diopter per decade. So you want to account for that in your astigmatism planning. Leave the patient with a little bit of with the rule astigmatism. Spherical changes can occur in pseudophakic patients also. So you have to advise these patients of the possible need for corneal refractive surgery in the future if they want to retain excellent uncorrected acuity. And so we're still waiting for accommodating IOLs, and the wait continues. Thank you.
Thank you very much.